Dr. Duvall.
Yes, welcome back. And when you get that free card, don't forget to pay the taxes on it. You are liable for that.
You have to pay the taxes. That's right. Patrick will do that for you.
So we'll talk a little bit about transesophageal echo. Obviously, this is something that is heavily relied upon in the OR. It doesn't really matter which cardiac procedure. Transesophageal echo is essentially, I would consider, kind of standard of care at this point. And so whether that's a 2D, standard 2D, or whether it's a 3D echo, that's depending on what procedure you're doing. But a 2D echo is pretty widespread and readily available everywhere. So the premise behind that is it's ultrasound. It's a probe that goes down through the oropharynx into the esophagus, and then based upon where you position it in the esophagus or advancing into the stomach will determine on what structure you're looking at. And it's basically just a long tube with an ultrasound probe on the end. It can flex, it can extend, it can twist, it can rotate. And so it can give you any number of different anatomical views from within that area of real estate, depending on what you want to look at. So on the screen here, we have what is essentially echocardiogram with a probe in the esophagus into the stomach and into the antrum of the stomach. And it's looking back towards, flexed up slightly towards the left ventricle. So you can see, based upon where that echo probe is, what structures you're able to look at. So from there, you can slide it back and forth along the base of the RV and LV to get any number of views. If you're looking at the mitral valve, you'll obviously pull it back closer towards the esophageal hiatus and almost back into the esophagus itself, or push it down further in, and you can get almost all the way out to the left ventricular apex. You can see the superior and inferior vena cava. I know that you guys have waited patiently while the surgeon tries to put the retrograde coronary sinus catheter into the coronary sinus, and the anesthesiologist is frantically trying to give the appropriate view. Those sorts of things are kind of advanced techniques, so to say, but they do work.
So I have a question about this, though. I assume the depth of field is adjustable, and that they can, because how do they know how wide the areas that they're looking at, how deep, and then can they adjust that?
Yeah, they can. And so based upon the frequency of the sound waves and also the depth of penetration or the strength of the signal, you can look something very shallow, something very deep. And so there are a lot of different ways to change exactly what you're looking at. Because, obviously the heart is a 3D structure. Yeah. It's got depth and it's got rotation and orientation. And depending on the patient's body habitus and the rotation of the heart, is this a big, huge left ventricle that's dilated out? Is this a very small one in a fairly normal patient? And those things, you can change those settings on the probe to kind of get your picture. And that just comes with technique and time and practice using it. But yeah, you can actually change things. And on this diagram here, you see that the probe is in the esophagus, but it's rotated posteriorly. And so you're looking directly into the aorta.
Yep.
So this would be beneficial, obviously, if you're putting a balloon pump in, advancing a wire up the aorta, and then followed by a balloon pump. If you're worried about a dissection or something along those lines, there are certain images that you can see. And when we're putting in the balloon pump, you can see the esophagus and the left subclavian do cross and intersect, so they're able to look at the arch. And the picture that the anesthesiologist is wanting the surgeon to see when they're putting the balloon pump in is you can actually see the orifice of the left subclavian, or the takeoff of the left subclavian, and that's where you want the balloon to stop just prior to that, and the wire as well. So it's very beneficial in that regard, and it's a real-time image. You don't have to wait for them to wheel in the x-ray machine or anything along those lines. You can look at the changes that you're doing with the pump or with your resuscitation or fluids or medications in real time as to what the physiologic effect is. This would be a great view if you're looking at the atrium and you're also looking at the LV. You can see the short axis of the mitral valve kind of looking directly through the mitral valve. And then you can get pictures of the aortic valve, but this is a transesophageal long axis view. You have the short axis, which goes essentially up and down, and then you have the long axis, which goes along the...
That makes sense. So if you're looking for MR, that's where you're looking.
You're looking there.
You do a mitral repair, that's your view.
That's your view. You're looking straight down the barrel of the gun into the mitral valve. You can see the anterior and the posterior leaflets. You can tell oftentimes which direction that the jet is emanating. Is it posteriorly directed jet? Is it an anterior directed jet? Can you see reversal of flow in the pulmonary veins, meaning wide open MR? How good is your repair? And you use that as the comparison image for your pre and post repair.
Yeah, and those are really good. I mean, that's of course, we could have this discussion, I know, afterwards, but, do you check for your repair with the heart? I mean, doing it on pump wouldn't make sense. You really have to be filled up. You have to get your SVR, what it's going to be, some physiologic value, normal blood pressure, in order to really assess it. I mean, I have done some cases over the years for some folks who checked it and didn't like it, but then rechecked it with maybe not quite what you're going to need and said, oh, this is going to work. This will be fine. They're going to have to just live with this and then come off pump. And, it was much worse than what it really showed. Mm-hmm. So how do you address that? I mean, we could talk about that later.
We could talk. I mean, a lot goes into that. I mean, dealing with systolic anterior motion of the mitral. It's there, but they're not under. That the patient's oftentimes not under normal physiologic circumstances. So you give volume and things along those lines, and you can address that, and you can make the SAM go away. I mean, the pro and the con of all that is you can make the picture look as good or as bad as you want, depending on what therapeutic maneuvers you're doing. Mm-hmm. And I think that I think the basic premise is if you try to get each patient to kind of their baseline volume status and have the ventricle as normal as it was prior to, then that gives you an idea how well that repair is going to be. I mean, is mild good enough? And you want trivial? At what grade do you put trivial mild becomes moderate? There's a lot of nuance into that. Mm-hmm. And that really kind of comes with experience, I think. Mm-hmm. And it's really kind of hard oftentimes to discern those facts. You can do obviously some physiologic measurements. What is the size of the orifice? What is the area under the curve of the regurgitant jet and things along those lines where you can actually quantify the regurgitation versus, that looks pretty good, Mm-hmm. And so I think that in cases like that, taking some of those advanced measurements are important.
Mm-hmm. Do you need a cardiologist for that to come down to the room and actually evaluate that? Or can anesthesia really do this and do it well enough? Do they require some kind of special training in order to be able to do a true TEE examination and give you the information that you need? Or can it be just sort of learned OJT?
Yeah, so I think that really depends on the program in which you're practicing. There are ultrasonographers that are cardiologists as well as anesthesiologists that are both good and both bad. I think it really depends on the comfort level with the anesthesiologist that you're working at and also the construct of the program that you're practicing in. Take, for example, one of our community programs. I have an excellent cardiac anesthesiologist, fellowship trained, carries a basic and an advanced echo certification. Extremely confident with her measuring all those sorts of things that we just talked about, discerning the degree of reversal of flow in the pulmonary veins. Is the left atrial appendage truly and completely occluded with a clip or oversewing when you're doing a repair? Is there any paravalvular leak? Things along those lines. Trust her wholeheartedly and completely. In one of the other programs, not so much. They have a basic echo certification. They've been doing hearts for a long time. They can certainly resuscitate a patient. They know all the nuances and how to appropriately address RV failure, LV failure, medication-wise, et cetera. But when it comes to the advanced measurements on an echocardiogram, often would rely on the cardiologist. And also, kind of my relationship with that referring cardiologist, is it somebody that tends to be hands-on, or is there somebody that's okay with the surgeon, kind of taking the ball and running with it because we've developed a relationship of trust? And so there are a lot of different things that go on in the background that you try to respect as a physician and as a program and as a community. And I think it's very specific to the institution that you're practicing. So I've done it all ways. I've done it all separate ways. And if there's really a concern, I'll call the cardiologist and they'll come into the room. That's usually in extreme circumstances or if we have an unexpected finding in the operating room.
So let me ask you this, if I can, and I think we have some images, right? Hey, Roger, if you want to, while I'm asking this, so here we are at essentially a perfusion conference. Okay, so this program is approved for Category 1 CEUs through the ABCP, and that's it. So we're focusing on perfusion. Now we may change that later and add credits for nursing and credits for physicians and all of that. But right now it's Perf Web, Perfusion Web webinars. Do you think, what's your viewpoint on perfusionists since we have made this, essentially imaging as a topic for a webinar? I think it's important that we have a basic understanding of what's going on. But I'd like to get Patrick your opinion, but first let me ask you, and then I'll ask Patrick. What do you think about perfusionists wanting to learn more about this to be able to be a part of, what the team may be discussing?
Yeah, no, I think I think it's extremely germane. I think it's extremely important. I think that in the advent of modern cardiac surgery, you have the heart team approach where everybody plays a role, but everybody needs to understand everybody else's role. And I think that the more people on the team you have educated as to what you're doing, why you're doing it, I think makes the whole process much more streamlined, efficient, and also proficient. I think that if you guys as perfusionists understand what we're looking at when we're placing an intra-aortic balloon pump, and you're able to correlate that with the dicrotic notch and the augmented pressure, et cetera, and those subtle things that we may be changing, and you associate that with what you're seeing from your end, things that you're doing in your realm or your sphere of practice, I think the better off everybody is. And it also helps you pick up subtle things that you may notice that I don't see because I'm either multitasking or simply focused on something else.
And you're also looking through those loops sometimes or looking over them. And You're right. We, perfusionists, we have a very wide view. Hey, Roger, can you pull that website up for me on the internet? Thanks. But Patrick, let me ask you this if I can. What is your view? How comfortable would you be after having gone through this experience here with an X-ray? Or let's say after the TEE, making a comment saying, man, that balloon catheter looks like it may be in a little bit too far, or the ET tube, or whatever it may be. So whatever you may be seeing, how comfortable are you? And are there times when you're more comfortable than not, depending on who you're working with?
Right. Well, that's a big point. Depending on who you're working with, some people don't want you stepping on their toes and saying, hey, listen, that's. Some people, they want their jobs to be very delineated in the operating room, and they don't want anybody else to be, stepping on their feet or maybe demeaning, putting down what their diagnosis is of something. But in my opinion, I think it's important I agree with you entirely that one thing I've noticed lately is that there's much more of a team approach in the operating room than there was when I started 20 years ago. And as a perfusionist, when you can step in and almost step outside of your little scope of practice in the operating room and show that you have some knowledge, it adds an enormous amount of credibility to what you're doing, I think.
Well, I think so too. I think that's been our problem. I think that perfusion, I feel like we have as a profession pigeonholed ourselves over the years to basically this machine, and we run this pump. And I'm seeing it change. I mean, we started off with, we understood everything. We used to scrub, we had to put lines in. In the old days it was like that, but then it got more and more and more and more and more contracted to one thing. I mean, there are programs right here in Houston where the perfusionist doesn't even manage the blood pressure. I mean, they give no medications whatsoever. Everything is done by either anesthesia or somebody else. They essentially, all they do is watch their level, turn the pump on, turn the pump off, and that's all they do. And in some circumstances, that's sort of all they know, so they leave and they go someplace else, and they're a fish out of water. I think knowing more and understanding, we're not physicians, and I think when your point about stepping on toes, but you're also, you're a mid-level, but you're not dumb. And if we know it should be welcomed when somebody says, "Hey, is that?" And it doesn't have to be, "Oh, you idiot." I mean, you don't talk to people like that. But if you made a comment, if a perfusionist came up to you and said, "Man, that septum on that echo looks like it's bowing in, or something like that," or makes a comment about something, does that give you a higher sense of confidence in that perfusionist and that professional, that you feel better about? That's the person who's running your pump, somebody that could actually engage with you and talk about something like this.
Yeah, I mean, I personally like feedback. I like people to talk, and if I were, this would be a great topic for another time. Is the things in the operating room during the conduct of a procedure that irritate, or that's a bloody field, and we're communicating the whole time. He's like, well, I've got my suction all the way up. Well, okay, turn it off, turn it back on. Maybe you've got the atrium sucked up into the side holes of the cannula, something along those lines, or. I think that's very important. I think a good example would be that with, like we just talked about a few minutes ago with the x-rays and the balloon pump positioning. We do all these little rudimentary things to eyeball it, hold it onto the patient to measure about where the thing should be. We use transesophageal echo in the operating room to position the balloon pump in the correct place. But then that whole black box, that Pandora's box of patient transport comes up. And we know, because you guys are manning the balloon pump during transport and immediately after, that the balloon pump's at 35 centimeters. It's sewn in place. But just because it's sewn in place, that doesn't mean that flexing the hip or rotating the patient, that balloon
Impella.
Impella would be another
huge.
one. And so you know that the balloon pump is at that level. We go up to the ICU. Anesthesiologist is giving the report to the nurse. You're giving a report to a nurse or something like that, positioning the balloon pump. And the nurse calls out the balloon pump's at 38. He may be the first person that hears that or realize. I don't pay attention to that sort of stuff. The anesthesiologist is giving her report. She's probably not even listening to that. Chest tubes at 300 cc's, we got 200 out urine in the Foley, and the balloon pump's at 38. Well, Patrick could be, the balloon was 34 when we left the room, and you could see that, that the blood pressure is a little bit different. The waveform is different. The dichrotic notches move. Something subtle that would correlate with the balloon pump being moved. So we're getting a chest X-ray with a more heightened sense of urgency, or we have we know that we need to look at that immediately because that may become an issue, or if it's advanced, God forbid, if it's advanced, into the carotid or something like that. But I think that's where it's
potential stroke. So it's important. It's not benign.
It's important that we are to some extent cross-trained at each other's roles. That way we have a kind of a complete 360-degree view of what's going on.
That's why I found it odd when you were like, I want to step on people's toes. Okay, so this website, let me answer this call. We have a caller. Hello, you're on the air.
Good morning.
Hey, how are you?
I'm good. How are you?
Good. Who's this?
This is Melissa Mattis. I'm a perfusionist. I work at the VA hospital in Washington, D.C.
Great. Hey, Melissa.
Been doing perfusion about 20 years. I think your program here is fabulous. Thank you very much for allowing us to get CEUs at home.
Good. Don't forget to subscribe, thumbs up, and share us on Facebook. Don't forget those things, okay, Melissa?
I have done all of that, most of that.
It's like voting. Vote early and often.
Well, I'm selfish in that I want to do all of that so that you will keep doing these and making these available.
Oh, fantastic.
So awesome.
Thanks.
And we're a little shocked. We've got 2 of us, so sometimes we have trouble getting coverage. So this is a nice way to be able to get our CEUs.
Great.
And as far as your content goes, what a help it is to be able to see, have everything explained right there on the screen for the TEEs and the X-rays. Anything that we know makes us a better perfusionist. So we have cameras in our lights, so we can see everything that's going on at the field, and I think that helps us tremendously. But I think the more that we understand about what's on the X-ray and what's on the TEE, we are more able to act as a great team member. And
well, exactly.
intelligently.
Yeah, I think you bring up a very good point. Exactly. Speak intelligently about what's going on and being a part of the team. I think if
Absolutely.
I've had this discussion with several colleagues, and if you want to be part of the team, then and you want to be able to engage with a Dr. Duvall or whomever your physician may be, a different name, a heart surgeon that you're working with, or cardiologist that you talk to, or anesthesiologist you talk to. You have to be able to talk at their level. It's not their
Absolutely.
job to talk at a lower level. It's our job to talk at an upper level. Not that I'm implying that we're at a lower level. That's not what the point that I'm trying to make. I think you understand my point. So the more we learn, and learning is just so critically important. I think our perfusion license is basically a license to learn. That's what it is. Mm-hmm. And if you once you stop learning and you think you know everything, it's time to retire. I think you're done at that point.
Well, I just appreciate it, and thank you very much for all that you have to offer.
Well, thank you so much, Melissa. I appreciate it. Let's stay in touch, okay?
All right, sounds
you
good.
can even request being friends with me on Facebook, because we have the conference webpage, so then we can communicate back and forth.
That sounds great. Thank you.
Bye.
Have a good day.
You
Bye.
too. Bye. So this website I found is so cool, and Dr. Duvall, you have control of it, but this is actually from the University of Toronto, from the Peter Munk Institute, which is where Dr. David is from, who is our award recipient for the at the New Orleans conference, our Crystal Heart Achievement Award recipient this coming June. So this is from his center, and this thing, just show everybody what this thing can do. It's just awesome.
So this is a awesome learning website, a good tool. You can sit around and play with it all you want, but it basically goes through all the different views that you would see on a transesophageal echo. And so this image here on this side will rotate the heart 360 degrees, so you can see, number one, where is the echo probe? The esophagus has been removed from this, but if you imagine, it's in the esophagus. And so if you know what image you see on the right, you can describe the echo position on the left. So this is going to be a mid-esophageal, two-chamber, because you have two chambers of the heart. You have the left atrium and the left ventricle. And this is a long axis because you're seeing the entirety, the length of the. So this is of the heart on the left side. So this is a mid-esophageal, two-chamber, long axis view of the heart. You've not done anything profound. You've just described what you're seeing. And if you hearken back to the chest X-ray, the biggest thing is just to start talk about what you're seeing. And so, as you gain facility with this and a little bit more experience in looking at these sorts of things, you're able to tease these out. So you talked about talking up instead of talking down. Yeah, to a certain extent, but I think it's part of my job as a surgeon is to help educate and facilitate the discussion. And so, we can talk both ways, and eventually everybody's on the same page.
Absolutely, I agree with that.
It's not a singular effort on that part, but
you can grab that heart and move it. You can actually just grab it and move it.
yeah,
Isn't that? And then the other thing you can do is see down there where it says View Slice. If you go straight down to the right, and you click View Slice, it actually cuts it. Look at this. Watch this. Just click there. Yeah, click it once. There you go. It just slices. It opens it up so you can see the internal structures of what you're supposed to be looking at.
this is just a really cool interactive website.
So on the right side, I see the LV. It's obviously the mitral valve. And how would you describe that? Now it looks like the valves are coapting and all of that leakage and all that kind of stuff, but would you say that's a pretty normal LV?
That's a normal looking, beautiful LV. If they could all look like that, the world would be a happy place. So the things that I look at when I'm looking at this is, and I'm a visual kind of guy, street signs and all that sort of stuff. I kind of get lost in that, but I'll recognize an oak tree or an old building or something like that. I'll know that's the way to go. So I kind of try to correlate. So I know where the esophageal probe is, right? It's in the mid-esophagus, which means it's posterior. And then looking at here, you can see it's kind of coming in a little bit off to the left side of the heart, long axis. So I would expect the probe is slicing through the long axis of the heart. The first thing it comes through is the atrium. And then the last thing it goes through is the apex of the heart. So on that, with that in the back of my mind, I'll know that the echo probe is essentially here. It's at the top of the screen. It always is. And so the first structure that I get to is the left atrium. And then the next structure as I'm walking through the left atrium into the left ventricle is the mitral valve. And I know that based upon where the echo is, in some basic cardiac anatomy, I know that this is the anterior portion or the interventricular septum, and this is the posterior wall of the ventricle. So knowing that, I know that this is the posterior mitral leaflet, this is the anterior mitral leaflet. And so now when I'm having a discussion with the anesthesiologist, you know why I'm talking in those, using those words, and we're talking about the same structures.
Which one's P1 versus P2?
Well, that depends. It depends on where that echo probe is. As you rotate that echo through, you can gain P1, P2, P3, depending on where it is. But I think a better view for that would be the short axis view, where you can look when you're actually looking down the origin of the barrel of the gun, and you can see the anterior leaflet here and the posterior leaflet here, and you can see all the different segments of P1, P2, P3. Okay. So you can't discern everything just from a single view. I think that would be a mistake because it's a 3D structure. Don't ever make a decision based upon a 2D image unless you've looked at all the 2D images. So things that I look at when I look at this view, I think this is a very important view, especially if you've done a mitral repair or if you've opened the heart in any way, you're looking for air. Usually the air will hide on the interventricular septum because if you're looking at the heart, that's kind of the most anterior portion of the left ventricle is along that septum. And so you'll see the air which will show up bright on the echo sitting in this area, and then you'll also see it bubbling as it comes out through the pulmonary veins into the left atrium and through. And so you could look for air. The other things that you could look at if you've done a coronary revascularization, I know that the guy had a 100% circumflex lesion. In the pre-op echo, the posterior wall was sluggish or down, hypokinetic, or the apex or the ventricular septum. You can compare that based upon this, and you can see if it's squeezing. Here you can see all the walls are moving concentrically, evenly. There's no paradoxical motion. There's no akinetic area that's just sitting there that's along for the ride. You can look at the mitral valve through here. This is if you apply color to this, you can see if there's any regurgitation. Oftentimes when they have circumflex disease, you revascularize an OM, that MR will get better if they've got ischemic mitral regurg, and you can easily see that from this view.
So should every program that does cardiac surgery have at least a 2D echo?
I think so. I've not seen a program that doesn't have it. I think that it's essentially standard of care. I mean, think about it. You've seen, and this kind of steps off into the philosophical aspect, and it's a good topic for discussion if people want to call in and weigh in on this topic. But I think that you see a transition in medicine in general to not quantity but quality. We're getting away from work-based RVUs to reimbursements to quality-based reimbursements.
And pay for performance.
Pay for performance, all those sorts of things.
Quality matters.
So it's not just the mechanical aspect of doing a bypass, it's how well did you do the bypass. I mean, in all of our cases, we have an echo, so we're able to assess the function of the LV, of the myocardium, or whatever it is we want to look at. But we also check the quality of the bypass grafts. We use a flow probe, coronary ultrasound, to gauge not only what is the flow going through that bypass, what is the quality of that flow, what is the ratio of systolic to diastolic flow, the pulsatility index. Is this a quality?
The Medistim device.
The Medistim device. Is this a quality bypass? If I know that the pulsatility index is low, less than 5, which is ideal, and the flow is low, that could be because either the vein is not great or that the outflow and that vascular territory is not great.
Runoff.
You know, but there's nothing you could do about that. But the pulsatility index, if it's extremely high, that would make me think that I put a suture through the back wall, or I took a too deep of a bite, or something along those lines, something that is my fault with the anastomosis, something mechanically wrong
Or
with
potentially needs an endarterectomy.
endarterectomy, or revising something, or a classic example, and I've done this and I've had this happen, is I do a Lima to LAD, and I always tack the fascial portion of the mammary pedicle to the epicardium so that pedicle graft doesn't twist or rotate and kink off your bypass. Well, in tacking down that fascial portion of the mammary down onto the epicardium to prevent that torsion, I twisted the anastomosis a little bit, which caused the pulsatility index to go extremely high, which would translate into long-term poor outcome for graft patency or flow or quality. And so I simply cut that suture, and all of a sudden the pulsatility index went back to a normal. And so that there was a simple maneuver, testing that bypass graft. I never would have thought about that. Looked good. I'll throw perfect stitches every time. Why would this be bad? You know what I mean? And so
But that's because you do all your cases on pump. On pump cardiac surgeon.
And so, those are some of the metrics that we introduce into medicine to verify that we've, number one, done the right job, number two, done a good job, and number three, protected our outcomes and our reimbursement, our livelihood, et cetera.
And also documented that you've checked everything you can check in order to assure
Right.
the patient, because at the end of the day, the patient wants to know that, they want to know that you are measuring your own quality. They want to know that you're, checking yourself.
Yeah.
I mean, I would.
Yeah, I mean, obviously you would like to police yourself rather than somebody else police you.
Clearly.
And it's a good communication tool. We talk about communication being key, and the more that people know and are educated with what I do and what you do, et cetera, the better off the outcomes are going to be. It's a wonderful tool for talking to the cardiologist. These are the bypasses I did. These are the flows that we achieved. The pulsatility index is great. So they're like, why is there only 17 mLs per minute going through this graft? Could be lots of reasons, sir. These are the reasons that it could be. I know that the bypass was quality because my pulsatility index is this. Mm-hmm. And so it becomes a good way for you guys to communicate the effectiveness of the bypass, perhaps the poor quality of the targets or the runoff, et cetera. It just gives you another tool in your toolbox to have that Socratic discussion about patient care. And I think that ultimately all these snippets of information, you guys understanding what we're looking at on a TEE, builds a robust program where everybody has confidence in the program. You have good quality outcomes, and you know why you have good quality outcomes.
Mm-hmm. That makes a lot of sense. I think actually we're going to do a webinar on validating the bypass grafts, validating the quality of the bypass grafts, and why that's important. And I think that should be a standard of care as well. But I think we did TCD, our first one, if you remember. Mm-hmm. And of course, I think that should be a standard of care. We're supposed to be perfusing the brain, but we're getting off topic. I realize that, but we're supposed to be perfusing the brain. And I know that there exists the cerebral oximetry, but with everything that I've read about it, I can't even say it's better than nothing. It's as good as nothing in my view. I think we need to go with TCD, and I think it needs to be a standard of care. But we can have that discussion later too. But you want to look at some other images, some other fun stuff? There's another one coming up. Yeah, it takes a minute to load.
So sometimes the anesthesiologist is able to get this great picture with TE that shows the aortic and the mitral valve in the same frame. Mm-hmm. Where are they looking at that from? Is that something that's shown on this?
Oh yeah, we'll get to that. That's not going to be on this view, because you think about, this would be something cool that you guys could do. You just get a little heart model, just buy one online, mm-hmm. stick it back there on your pump.
And put the probe where it is.
Yeah, and you know that you say, this is a mid-esophageal thing, and you could just take your little pen and you could hold the heart and you'd be like, okay, yeah, there it is. Now I know what they're looking at. And then you can, if you have that image in your mind, and it becomes down to anatomy, physiology.
Well, now
over.
Now I know short axis and long axis.
Yeah.
I'm going to be like an expert.
Yeah.
I can't wait till
Yeah.
I do the next case.
There's nothing magic about this. It's just learning the nomenclature.
Now that looks like a pretty good valve and a pretty good ventricle to me too.
It does, and this is really kind of the same view, but the probe is oriented a little bit differently. It's a little bit higher. It's a little bit twisted, and I think they're indicating that by the red line. So if you look at the image on the left, you're kind of taking a different slice of the ventricle, and so that gives you your different commissures. So you talked about P1, P2,
Yes.
P3, A1, A2, A3. Earlier, you can see by just manipulating that echo probe in the esophagus, you can move along that mitral valve to look at a different section. And so this is the commissural view. So these are where the commissures are. When we size the mitral valve to a ring, et cetera, or even to a replacement, we measure the commissural distance. That's what the valve sizes are based on. And so this would be one of the views that you look at. And the other thing is you move that echo probe along that axis of the mitral valve. You can see the subvalvular apparatus. You could see a flail leaflet or a tethered cord or something along those lines. And it just gives you a little bit better idea of what your pathology is going to be.
Hey, Roger, can they see the actual website address online so that they can?
Yeah.
Okay, good.
It's kind of small, but yeah.
Okay. If you need it, email me and I'll email it to you. But
So-
this is just such a cool.
And so this is
Right.
kind of getting to what you were talking about, Patrick, a minute ago, seeing the
Yes.
mitral valve and the
Love that
aortic valve. So if you were to describe this aortic valve, and how do you know it's an aortic valve?
Tricuspid.
It's tricuspid, yes. So this is a tricuspid valve. Is this a long axis or short axis?
I don't know.
Think about it.
Yeah.
Joe,
Short.
this is
Okay,
a short
tell me
axis,
what we're-
okay?
yeah, but-
So a short axis, you're looking at a cross section, slice of bread, like on a CAT scanner, et cetera. That's the
Okay.
short axis. The long axis would be looking directly through it.
Okay.
Just think about the distance that the probe is viewing. Is it short or is it long? So if you're looking from top of the left atrium and going all the way down to the apex of the left ventricle, that's a lot longer than that little section that it's going across right there. So, I mean, is that fair enough to
Yeah.
say it that way?
Yeah. And so you can see that this is a short axis view of the aortic valve. So once you've done your aortic valve replacement or you have your transcatheter valve in place and you're assessing your work, this would be the perfect view to look for a paravalvular leak because you're going to see that around these edges. You're also going to be able to tell the function of the leaflets of the valve that you've just put in or replaced or repaired. You can see that they're coapting in the middle. They all meet. If you were to think of a normal valve, they coapt in the middle, or the prosthetic valves, the tissue valves that we put in, they always will have a little central regurgitant jet because those valve leaflets, as they come in, they're circular and they coapt here, but it's a 3D structure, and so they don't always just have a tight seal right at the center portion. So you should always see that little bitty regurgitant jet through the middle, and you could look at the image and you can see that it doesn't coapt perfectly right in the center.
That's interesting. Every time we do a valve and we see that, I've always noticed that little bit of regurg, and I didn't know that was by design.
Yeah, and so that's
And
just
some valves have washing jets, right?
yes.
Some valves, when they first started putting them in, everybody thought there was a paravalvular leak. Oh my God, there's a leak. But actually, it's designed to have these two jets, and it washes the pivot points so that it doesn't develop any kind of, thrombus or gradue or fibrin or anything like that. And gradue, that's a Louisiana term for whatever. You knew what it was. You knew what gradue was. And Vicky knew what it was. But that's to prevent those pivot points from getting stuck. Now that's an interesting one.
So I think this is the specific image that you were looking at. You see the mitral and the aortic valve.
Yeah.
And so would you classify this as a long axis view or a short axis view?
I am going to take, I got 50% chance of winning, and I'm going to go with short access. I don't understand the concept yet. I'll be honest.
You had
Yeah.
50% chance of winning, which means 50% chance of, you don't get the prize.
Is it-
I'm
so is
sorry.
it short-
There was a prize with this one if you
Hopefully-
got it right.
well, hopefully
let-
there's other
rotate
people that have the same
rotate
question.
But rotate the heart.
Is short access closer
rotate the
to
heart.
the valve, or is it?
Look at the red. Keep coming around all the way.
Here, let me put this.
Yeah, see that red? Okay, see the lower right-hand corner? Right there. Look at how long that
This is a good view of
probe
it.
is.
Okay, so the probe is sitting here in the mid-esophagus. You're directed towards the heart, obviously. And this probe, the way the ultrasound, or the sound waves are going, is down the long axis of the heart, right?
Okay.
You see?
So we're seeing a deeper slice.
Yeah. The other thing is it says LAX, which is long axis view. So those little
Yeah,
things.
I should jump.
But if you compare this, we know this is the aortic valve. You see the sinus of Valsalva here. You see the leaflets moving. This is the mitral valve. This is the perfect place where you pick up SAM when you're looking at a mitral, as is in this view. You'll see this leaflet going over here and encroaching on the left ventricle outflow tract, the LVOT.
Mm-hmm.
Okay, so compare this view, long axis, to this view, short axis. Same valve,
Yep.
probe is basically in the same depth within the patient. It just depends on how you have the probe oriented that you gain the short axis versus the long axis.
So that probe not only goes up and down, but it also flexes.
Flexes and it rotates.
Right? And rotates, right.
So it articulates just like your hand. So this would be the short axis because you're looking across the aortic valve. Long axis view, obviously much different. Same structure, longer. You could see appendage.
I see air.
You can see air. There's probably some air in there. Could be some air. They may have just done a bubble test, or this may be a post-cardiotomy that they just have this snippet here. But this is the left ventricle, and this is the perfect view. You could also would see a paravalvular leak here. You would know that when you apply color to this echo, you will have your small central regurgitant jet with an aortic valve replacement. And then if you have a paravalvular, you're going to see that here on the sides. Anyway, we know that we've done this enough that a small amount is okay. Those oftentimes will heal with time or whatnot. And once the sutures and the pledgets become incorporated, those will just go away. But that's where you look for it, okay? Now, if I'd replace this valve and I have a big paravalvular leak and then I have a central jet that's shooting off to one side, I would think that one of my sutures has come apart or my repair was inadequate, and he's got an impending disaster. And so you would obviously go back on pump and replege and interrogate that. But this is how you do that. And then the anesthesiologist, depending on their comfort level and their skill, they can calculate a gradient on the valve that you just replaced. The other day we did a aortic valve replacement, mechanical valve. The lady had a BMI well into the 40s.
Wow.
Big patient.
In a little
It's
person's
very
body.
she was a gymnast inside,
Little
and she had a 19 millimeter root, and so we can't replace that body with a 19 sized Onyx mechanical valve, and so you have to do a replacement.
Yeah.
So not a replacement, excuse me, an annular enlargement procedure. So we did that, and we're able to get a 23 in. But that's important because if I just put a 19 in, which would have fit, if she had calculated a gradient across that, the patient would have obvious aortic stenosis.
Yeah.
And so you can, when it
And
becomes...
she wouldn't have. I mean, it wouldn't have been a good outcome.
No,
for
she
her.
would have done poorly long term. We would have replaced a stenotic valve with a stenotic valve, essentially. Physiologically, at least. And so, you can make those measurements here. The anesthesiologist can measure the annular diameter. This is the view that they do that. They measure the distance from here to the distance here. And they're able to give you that EOA, annular size, etc. So those are some of the measurements you can make just with that one view alone. So this is our view when we're talking about putting ECMO cannulas in. If you're doing femoral venous cannulation, et cetera, knowing if your cannula is in the right place, if you're placing them before you open the chest. Perfect clinical example of this is you've got a dissection involving the root, and you may have a contained rupture, and you want the patient to go on pump before you open the chest so you don't have to crash on, so you're going to femorally cannulate. You can't put your hands in there or look in there to see if your cannula is in the right place, so you have to rely upon your anesthesiologist and their modalities to know if your cannulas are in the right place. So you femorally venous cannulate, and she gives you an esophageal, mid-esophageal, bicaval view, meaning the probe is sitting right about that level anteriorly. You can see that the line is coming directly out in this orientation. So you have the superior vena cava, inferior vena cava, right atrium.
That is
So
really
you
cool.
will be able to see
That is really
if
cool.
I'm putting an Avalon cannula in, you see the wire come down across the SVC, across the atrium into the IVC. Or if you're femorally venous cannulating with your dual stage cannula, the exact opposite is true. Not only that, on the Avalon cannula, you have that little marker that you could plant right here. And then if you were to initiate VV ECMO or you go on pump, you could see your jet going into the right atrium, so you know you're at the right level.
So we're sitting in the ICU at Hospital X, and maybe they don't have the most robust management of the ECMO patients. We that happens occasionally in some of the more peripheral community hospitals, and we want to get a TEE, and somebody comes in with a TEE and the probe, and they say, well, what do you want to see? We just simply need to ask for the mid-esophageal bicaval view, and that's what we're going to get.
Yeah, I mean, you could say, well, I need to see where the position of the cannula is. I want to know if it's in the right position. If you don't have somebody on the other end that understands what that means,
Right.
then you guys are at an impasse. You
Now-
can't find out anything.
Now, what could we do with this if the color was on, which I understand it's hard to get those, but so if that's the SVC, IVC, is that section, keep going down and to the left? Keep going left, right up a little bit. Is that the tricuspid valve there in that area?
No, I don't think that's going to be the tricuspid. This is, it could be, depending on where.
Like where would we expect to see that jet?
Well, you would expect it to go into here. Now, this is not the exact view to see the tricuspid valve, because if you look at the orientation of this, where is the tricuspid valve sitting? So you have an AP view of the heart, right? You're looking directly at it into the chest. You have your SVC here, you have your IVC down here, and then you have your atrium is here. Here's your right atrial appendage. Your tricuspid is down here. So where you have this thing open, So how would you see the tricuspid valve?
Rotate the probe.
You simply rotate the probe to direct the ultrasound waves towards this way, and you'll see the tricuspid.
Okay, so this same view, if they had it, we would be able to say, hey, just can you rotate it? Can you show me the tricuspid valve? They would know what to do, and then we would see the tricuspid valve. But you'd be seeing it from the backside, so that jet we're talking about would be a normal flow. So
it would be going away from you.
Right.
So it would be
which you would expect.
It would be reds and oranges.
Right.
On the Doppler.
So we need to be able to, could you see it superior to the tricuspid valve? Could you see above the tricuspid valve looking at the Avalon catheter exit point? Is that possible?
Looking from the tricuspid back towards the Avalon cannula?
But above the tricuspid, so that you can see that the flow is
coming towards
where
you?
it's coming towards you, that you knew you were just superior, that slice just superior to the tricuspid. Is that even possible?
You can, yeah.
You can.
Yeah. You should be able to, yeah.
Where you can see it, because if the flow is going away from the probe, that's what it should be doing.
Yeah.
And so all of the flow is going that way. You're really not going to see a jet. I wouldn't think, or would you?
Well, he said it was going to be red and orange going away
Yeah,
from
I mean,
you,
if you have a bunch of blue on your color flow, the blue's in the negative, which means regurgitation coming back towards the probe. That's what the colors is assigned to that.
Is that it, or is it reversed? Is it red towards the probe, blue away from
You
the
can
probe?
switch them on.
Oh, you can switch
Yeah,
them, okay.
but it's generally. but you would see regurgitation coming back. So if it's all coming back and on the side of
what
it,
I'm saying is that, look, here's the catheter, here's the cannula, here's the exit point, here's the tricuspid valve. The normal flow is that way. So if the flow from the cannula is going that way too, there's no way to determine where it's actually, or, if it's high, low, if it's really aiming, if the jet is shooting right at the tricuspid. I mean, that would be optimal. If you wanted to really be precise about where that cannula was placed, is there a way to do that?
no, you would look at the color waveform there, and it would be more of a uniform jet.
So it wouldn't be
So if it's high or it's low and it's bouncing off the leaflets or off the Coumadin ridge or any of those other structures in the heart, it's going to be creating turbulence, which you're going to be able to see on the color Doppler. Mm-hmm. If you have a paucity of that and it's more uniform, it's more laminar.
like a cone, yeah.
And you don't have all this turbulence within, that you're hitting it probably directly into the orifice of the tricuspid.
Okay, all right.
And you can move the Avalon in and out and play with it in a stable patient. You could play with it a little bit. And so that's why it's kind of nice to have all these modalities at your disposal, because it becomes a powerful education tool.
Sometimes the enemy of good is better.
It sure is.
Mm-hmm. A little bit of knowledge could be dangerous. Okay.
So this is a perfect view for positioning cannulas and looking at your cava.
I like that view.
Yeah,
That
it's a
is
very
really
helpful
cool.
view. It's a very helpful view.
And I think isn't there some with some clot in it? I thought I saw one earlier that was pretty cool. You go down maybe? Does it scroll any further down? It might. No, I guess not. I thought I saw some. Oh, we have another website.
We do.
We do, yeah. If you want, we can go to that other one if you want. Hey, Roger, can you show us that other one? Unless you want to address this one.
Oh, we can't. No, the
We
other
have
website.
some other good ones with some pathology too.
And then you have your basic, you have your short axis and your long axis, and you have your esophageal views and you have your transgastric views. And that just tells you which, so
Go ahead.
esophageal and transgastric just tells you where your probe is. Long axis and short axis just tells you the orientation of the heart in reference and relationship to the probe. And then you just start to pick out
And then
your
image
anatomy from
gallery.
there.
Oh, it's on it already. Image library. It's already on it. Oh, there you go, Doc. Okay, so here's some good ones. Can you read that?
Cardiac thrombi, that's the one you wanted to go to, right?
Yeah.
Let's just jump to it, huh? Should we do massive? Let's do massive.
Roger? We may not be, we may have a massive failure. Try clicking on one of those things. What's that?
Allow it.
Allow? Yeah, there you go.
Yeah.
Ah,
Yeah. So how hard can it be, right?
What do perfusionists do? We push buttons, clamp tubes, and just click it. Worry about the consequences later.
Mute alarms.
Don't do that. Please stop saying that on camera.
I'm bringing that back.
Stop
it's a
saying
throwback.
that on
It was a
camera.
throwback from the last.
So this is, Patrick, a short axis or long axis view?
Oh, come on. I don't know. I don't get that concept yet. But I'm gonna think about the idea that you had of, bringing actually a model of the heart.
Yeah.
And then, putting your pen there and looking at it and saying, you could figure a lot out that way. So no, I don't know.
Yeah, this is a
But
long
I do have
axis
a 50% chance of
It's
winning.
a long axis, okay? Because this is the aortic valve here. This is the long axis view. This is the left atrium mitral valve, okay? And so we're looking for, this is a massive LV thrombus, spoiler alert. And so, normally in the heart, the chambers where the blood is, are black, dark. The muscle will be lighter, white. Echogenic structures, okay? And so you see this in the left ventricle, which is abnormal. You shouldn't normally see anything in there other than just blood. And so when you start to have these echogenic structures within, you have to think of a foreign body or something denser than blood that's in there, and this LV thrombus would be one of them. And so this is a nice view if you're looking at that, and the patient may come in with some emboli. They wouldn't necessarily have a PE since this is left side, but they could have TIAs, they could have stroke, they could have, if they come in with abdominal pain and their creatinine's up or their LFTs are up and they get a CAT scan and they have all these little multiple areas of infarct or embolus, you would think, oh my gosh, it could be cardiac in origin. If they have endocarditis or something along those lines, you would see that on this study. And so you get a patient that comes in there maybe in septic shock with bilateral pneumonias, and they have septic emboli that are in their spines. They have an abscess in their spine, their spleen, liver, something like that. You always get an echo because that's one of the obvious sources. Is it's just showering off these little emboli or clots all over the body that causes the pathology. So this would be an example of a massive LV thrombus. And it can be subtle. Obviously, this is just one static image and one plane on a long axis view, parasternal. And then you can obviously change this and look at 360 at the heart, et cetera, to get a better idea. But that's what it kind of looks like, and that's what we're looking for.
So let's have some fun. Okay, so Roger, do me a favor. Let's cut the go to like a logo or something. You pick something out of your library, and then if people want to call in, put the call-in number up, or Patrick and I will try to figure this out. And hopefully somebody will call in. But if
help me out. Call in.
If you call in and you just calling in, you're going to win a prize. If you get it right, you really win a cool prize. You just won't believe it when you see it, when you hear what it is. But I'm not going to tell you what it is till you call in and get it. So Roger has to go. You're on logo, Roger?
Yeah, well, I'm just on camera.
Just on camera. Okay, they can't see. Okay, don't look, Patrick. Don't cheat. Look at me. I'm
looking at you.
eye to eye right here.
Yep.
Okay, no cheating.
So you want me just to pick something out?
Pick something
and
out.
you guys are going to talk about
And
it.
we're going to figure out what it
We need
is.
to figure out what it is.
It's not going to go well.
That's
So
gonna be fun.
you want a normal structure or you want some pathology?
Pathology.
Okay.
Yeah, we want something
We're going
bad.
straight to the advanced course.
Yes,
Okay.
straight to the advanced course. We're perfusionists.
Okay, yes.
Don't cheat, Patrick. I see you looking.
No, I didn't look
your
at
eyes
it.
over there.
It was right here.
That's right. I have it on my computer right here, so I win. No, I don't really.
You probably do.
No, I don't. I'm monitoring
Okay,
the
all right.
YouTube and the face, whatever it's called, FaceTime.
This
or
this is a
Facebook.
good one, and we're gonna
Okay, we're on?
So I
We're
have
on?
the
look now?
diagnosis is at the top of the screen. It's covered up. So
Okay. Okay, so anybody, so Roger, we're back live with the images. Okay, so there it is, whatever this is gonna be. And if you call in, and just calling in, you're gonna win a prize. If you call in and figure out what the pathology is, there's color, you've got down below. If you wanna see a particular image and try to guess it, you are gonna win the prize of a lifetime. Okay, so, all right, so let's see. Okay.
Well,
Gracious
should we
sakes
start,
alive.
or you want to just? I mean, there's one thing that's obvious to me.
So let's describe what you see in this top central image, the big one.
Okay, well, it's a 4-chamber view.
Yep.
I see the right atrium, right ventricle, left ventricle. See the septum real well. See the tricuspid valve. I see the mitral valve. I see something above the mitral valve that's kind of curious. Kind of looks like it could be a vegetation or something like that, but I'm not really sure without looking at more. But it does look mobile, like it's moving around a little bit too. So I'm not positive. But that's my instincts are telling me that. It looks like the ventricles are moving okay. The left ventricle doesn't look like it's emptying quite as well, but it's okay. And let's see if there's anything else that I can tell in this.
Can I mention?
Yeah.
I see on the right side there's sort of maybe a mass in the right ventricle.
You're seeing a mass in the right ventricle. I see what you're
I'll
talking
point.
about.
Can
Yeah,
I
I see it.
Don't you scroll that up.
Yeah.
And
I won't.
I see it.
Right,
Yeah, I see
right
what
there,
you-
though.
Yeah.
Okay.
You see what I'm looking at is that thing on the
And
left.
I saw what you saw too, right
Yeah.
there. Now that looks like a piece of bacon.
Yeah. Okay, so let's see another view.
Okay.
Let's pick another view.
So here's some of the Doppler images with color to them. And these are just loops that are playing over and over and over and over.
Can you make those bigger at all or no?
I can zoom in on a page.
Yeah, you want to zoom
Yeah.
in on that right there?
Yeah, because I can't.
Those top two color ones are bigger.
Yeah, that helps.
Yeah, that's nice.
Okay, now the heart rate looks like it changed quite a bit.
Well, that's just because of the loop playing
Okay,
over
it's
and
just
over at a
fast,
faster
okay.
speed.
So there's definitely regurg. I believe it's a mitral regurg. I hope I'm right on that. Not sure.
Say it with conviction.
That is
Okay,
a
well, now look at that
Right.
top. No, I see a
mitral
leaflet.
regurg.
I see a leaflet
That's a-
definitely going back up into the left atrium. There's definitely a that valve is not, in my view, that the anterior leaflet looks like it's going all the way
What
up
valve?
in the left atrium, up in the top left corner. Top left corner.
Oh, he's looking at the non-color part, the one in the upper left. Yeah. Oh yeah, that looks well. Wow.
I've never heard of a valve called the one in the top left corner.
Well, no, but okay, so
We're going to go back into academic mode here.
okay. So the mitral valve, the anterior leaflet of the mitral valve looks like it is flopping up into the left atrium. Actually, both leaflets look like they are, but the anterior one seems more obvious to me.
Well, this is a tricuspid.
Oh, it's
That was a trick. We don't look at that.
doggone it.
So
Tricuspid.
you want to take it off magnification?
Of course.
Okay. So if we go back up here to the 4-chamber view, we have right ventricle is here, interventricular septum here, left ventricle, mitral valve, tricuspid valve, and then respective atria. So if we were to look at the right-sided structures first, you can see that the tricuspid valve, overall the function appears preserved. I don't see any gross wall motion abnormalities. I don't see any paradoxical motion in the septum. I don't see any aneurysmal changes or anything along those lines. I don't see any air in the LV. I don't see any clot or thrombus in the LV. It all looks fairly regular and normal. What I do see that's abnormal is though the valve leaflets appear to be moving well and coapting well, there's some abnormalities primarily there, and you see it on several views or several cycles of the heart. And the heart is obviously moving. As the patient breathes in and breathes out, the heart will change slightly. So that's why you see the abnormality in that view, but even though the probe is not moving, the heart is moving. So it's not obviously a static structure, it's very dynamic. But you certainly see an abnormality here that's solid, echogenic in nature is how I would describe that. And then you also have an abnormality here on the mitral valve as well, which looks to be on the anterior leaflet, I would say, in this view, but I would never make a diagnosis or a decision based upon one view. I will look at all the other views before I say that. So that's what it appears to be. And then if you scroll down here, and are you able to zoom in on these now?
Of course.
So you're looking at the right-sided heart again, tricuspid valve. You can see that this is something very mobile in there. Not only is it big, kind of
That's not
circular
the
here.
leaflet going up. That's something
Well, you
stuck on
see,
the
well, you
valve.
see this going up here as
Yes.
well. This string going way up into the right atrium, which that shouldn't happen. So that could be a ruptured chordae. It could be a vegetation endocarditis. It could be a flail segment of that valve, something along those lines. So it could be something like that. And this is where it becomes important to put it in the clinical context of the patient. They came in, they have fever, chills, rigors, hypotension, septic shock type picture, and then they're looking for a source. Blood cultures are positive. They start them on antibiotics. Blood cultures are still positive. Somebody orders an echo. And this is what you find. And then down further on the mitral valve, this is a good picture of it here. You see that vegetation or that abnormality, right? And since we know, Patrick, that we learned the transgastric long axis view of the heart, when the probe is up here, we see the mitral valve in this position. We know that the left atrium is going to sit here, the left ventricle is going to sit here. So now we can describe this valve in more detail rather than saying there's something on the mitral valve. We could say there's something on the anterior leaflet of the mitral valve that's not really on the valve edge. It's more on the towards the annulus, et cetera.
Yeah, that's really interesting too. The way that different image is showing it in a different place, because it really looked like it was on the tip of the leaflet.
Look at it here.
It almost looks like it could be on the. It could almost look like it's moving back and forth on the posterior side.
Yeah, so like I mentioned, I would never make the
because it's a 3D structure, like you were saying.
Look at all the views before you give your verdict, because it can change.
Well, Jennifer Hutchinson says looks like there's regurgitation and maybe a ruptured cord prolapsing on the mitral. But yeah, I told her great observation, but I'm not sure that's where this is going. I've got a funny feeling that's not the answer.
It could be. It could be part of the answer. It could be all of the above.
Jennifer, you're still in the running. Still in the running for the prize. But you got to call, Jennifer. You got to call. You got to call to win the grand prize.
Okay, so let's go over what we've established so far. We have a normal functioning heart. The ventricle are both normal. If you have a pericardial effusion, what is that going to look like?
You're going to see probably dark around the heart.
That's exactly right. So we
And
know
the
that the
ventricles are
myocardium is going to be bright in the muscle. We've talked about fluid, blood, etc., being darker in nature. If you have an effusion, you're going to see that along the edge of the heart. So you'll see the outline of the pericardium, then you'll have a dark space, and then you'll have the heart.
Is it pretty well delineated when you see that?
If it's a significant effusion, yeah, it's pretty well delineated. So this patient doesn't have an appreciable effusion. I don't see an effusion. So we know that we have tricuspid pathology and we have mitral valve pathology. And so this is most likely the septal leaflet of the tricuspid valve. This is obviously, she mentioned a ruptured cord. I would probably agree with that here based on this view, as well as a vegetation on the tricuspid valve. Mitral valve, we have an obvious vegetation on the mitral valve, anterior leaflet, and this is getting into the area of the aortic root. So you talk about an aortic root abscess. So now that I see this echocardiogram, the things that would give me a sense of urgency would be, do they have conduction abnormalities? Because the AV node is in this neighborhood. Do they have a perforated septum? Do they have a left and right shunt? Do they have a defect there? If they have a root abscess, we're talking about a root replacement now, not just endocarditis and maybe a mitral valve replacement or repair. And so those are all the things that I look at. And so if you go down here and you look, and this is the area of the root abscess where we know that vegetation, what looks to be here, involving the annulus, is in fact not necessarily there, because that's the same region. On this view, this aortic valve long axis, okay? So the aortic valve appears to be functioning normal. I don't see anything really on it. I continue to see this abnormality in the mitral valve, but on this view, it seems further out on the leaflet. And then the root, or the annulus meets, you have that aortic mitral curtain that they talk about, is all in this area, and it looks normal. So I have two views that are showing me that I have some mitral pathology that's probably further out on the leaflet. And then this one view where it's hard to discern, it looks like it's more towards the annulus. This is going to be a leaflet pathology, not a root pathology or an annulus pathology. So I think this is a vegetation on the mitral valve as well. So this patient has tricuspid and mitral valve endocarditis.
Dirty needles. maybe, right?
Dialysis patients.
Oh, okay.
This is something that, I mean, that's probably one of the most insidious diseases where you have to have dialysis. And it's not unusual, right, to see a lot of endocarditis from dialysis patients. Yeah. But it could be an IV drug abuser as well.
And you'll see people that have healed endocarditis who never really got treated for endocarditis. They may have transient bacteremia or some fever or something like that, and they just get vancomycin on dialysis every week for months on end, and they'll have either subacute or chronic endocarditis, or they'll have evidence of healed endocarditis if you go in there for another reason.
Wow.
Not unusual. People that have indwelling catheters,
Yeah, that too, right. Yeah,
which are a
line
lot of your
sepsis.
dialysis patients.
Yeah, but line sepsis, if you have somebody that has you have a PICC line. I mean, I imagine that's, that those are long duration cannula. What about VAD patients? They've got lines coming from outside to in. I mean, any of these kinds of patients that can have this as a problem. And if they get a root abscess, that's a bad deal.
Big problem.
That's a big problem.
Big problem.
Yeah. I don't want that. If I go on dialysis, you know what to do with it.
Do we have anybody who wants to call in?
Yes, if anybody has any questions about these or would like to see some different views, call in now. I told you Jennifer had a comment. Jennifer, you at least will win something for texting, or chatting. But if you call in, it's going to be better. Or anybody else that wants to call in and maybe see something. You want to just pick a spattering of different things. We can pick something.
We'll put these up and we could talk about them.
I think they just enjoy watching us make fools of ourselves. They don't have to.
Right.
They know.
Speak for yourself. I'm having a hard time reading these, Roger. What are
They're
they?
small.
Oh,
Oh,
there we go.
nice.
Okay, high esophageal.
Oh, these are good.
I was hoping to see one where it shows the takeoff of the subclavian. Would be this view here. Which is somewhat in this view here. This is the view that you would have of the descending aorta heading into the aortic arch. And this may be kind of what they're trying to show here is the origin. This is where you would see the origin of the left subclavian. So if I'm putting in an intra-aortic balloon pump transfemorally and I advance the wire, I tell the anesthesiologist, hey, I'm putting in the wire. She knows to automatically go to this descending thoracic aortic view, which is essentially high in the esophagus, right? Where the arch is coming across the midline and then descending down into the chest. And so we have the esophagus probe high in the esophagus. It's looking away from the heart, essentially. Otherwise, we'd be looking at the SVC and getting into our bicable views. But here we are looking at the aorta. I'm inserting the wire up this way. And as it comes and hits the arch, she's able to see it there. And she can move this probe up and down inside the esophagus to get to that portion where the arch is coming around and the left subclavian artery is coming off. So she'll see that and she'll know that's right at that junction and that's where I need to stop with not necessarily the wire, but certainly with the balloon pump. And so she would have that view much like this. That wire would come up, you would see it. It's because it's echogenic, and then the balloon comes up, and you could actually see the balloon inflating and deflating within. Do they have one with the? Can you enlarge, please? Oh, this is good. Patrick, this will help you. Can you enlarge on that? So this is the deep transgastric view. So how do I know that? Because it says it at the top of the screen. No, I know this is a deep transgastric view because the probe looking at here, if you're looking at the heart, you see the right ventricle, the left ventricle, you have the LVOT, and this is the aortic valve. And in a dynamic structure, you'll see the movement of these things. You know, this is the interventricular septum, this is the left ventricle, this is the right ventricle. So if I have that image in my mind, where does the echo probe have to be? If you have that little heart model on the back station, you can kind of look at it and you can see that I'm looking at it. This is going to be a transgastric view. I know that because I'm able to see these two chambers readily.
And you're coming from looking up from the apex.
Yeah, I'm looking at the apex. They're exactly right. So knowing that the probe is here, looking up this way, I'm looking down the barrel of the gun, say that long axis of the aorta, but from the opposite direction. So I'll be looking up into the aortic valve. So the deep transgastric, almost kind of a retrograde look if you think about it that way. And we're doing just transesophageal because that's primarily what you're going to see in the OR. I don't think I've ever done a transthoracic in the operating room. I've done at the aortic probe to look at the root before you cannulate, etc., but not. Is there anybody online or want to call in to have a specific question about echoes or have difficulty kind of understanding the pathology? You can decrease the size of that or make it normal magnification. Roger? Can you decrease the magnification? Yeah. That's right.
Oh. Hey, Vic, my battery's going to go dead on my computer. Can I have a cord? Well, we'll probably make it to break. So anybody want to call in? Give your last chance. So we're going to wait. Why don't we just pontificate for the next 2 or 3 minutes, see if anybody calls, and we'll go from there. I do need to close this, so it's going to go dead. So with all of that said, is there anything about the echo? No, as far as imaging is concerned, 2D versus 3D, we talked about it being a standard of care. I wonder if there's programs that don't use echo at all in the operating room to do hearts. I mean, today.
I'm not familiar with any that don't. I mean, I think
we didn't for years.
I was going to say
I think probably every hospital has the capability, but there are probably some surgeons out there that don't rely on it, and that's probably a surgeon specific practice. But every
if
hospital,
you're doing valves, you have to have it.
I think it'd be criminal not to do that, not to use it if you're doing valves.
Yeah.
And even to this day and age, revascularization. I think there's so much useful information that I think that it's, we don't use swans as much as we used to anymore. Mm-hmm. And so the echo is another way to gauge your resuscitation. Where are you along the Starling curve in terms of your resuscitation? Mm-hmm. And how does the LV look? Is it full? Instead of looking at the heart and saying, it looks distended, it may look distended, but it may not be distended. If they already have a dilated ventricle, it's always going to look distended. Mm-hmm. And if they have a low EF, you're not going to see the myocardium wrinkling and crinkling with every contraction to let you know if it's getting distended or if it's underfilled. And so the echo is a great way. You could look at the transgastric short axis view where you see all 4 walls of the LV and how close they are. Is the ventricle or the walls, the septum and the outer wall, are they kissing during systole when they contracts fully? If it does, then that would indicate that it's underfilled, and you could need more volume to push it up on the Starling curve for hypotension rather than giving pressors or inotropes. So it can guide your therapy, which should be vitally important.
So let's talk about. Oh, thank you so much. Let's talk about ischemic valve dysfunction, because so you have ischemic wall motion abnormalities, you have ischemic valve dysfunction, you finish doing coronaries, you expect that your grafts are your grafts are good. You do the probe, everything looks great. Your pulsatility index, your flows, everything looks great. But you do your TEE, the ventricle looks like it's moving well, but you have moderate MR. And you know, it's kind of grading that is sometimes, I know, challenging. I mean, but it's more than you're happy with. At what point are you going to make a decision based on that study to say, let's go back on pump, we're doing a mitral rig, or we're going to replace, probably a rig. If there's no structures, no cords that are ruptured or anything like that, the leaflets aren't coming up into the atrium. It's just an ischemic issue.
So your question, well, what does it look like before you did the revascularization? Does it look the same or does it look worse?
Let's say it looks worse.
Okay. Does it look worse?
A little worse.
A little worse. So does it look worse because some of the wall is hypokinetic or akinetic that it wasn't before? Did we have a problem with maybe getting some air down a coronary? Do we have some hypotension that we're dealing with as well after the bypass run? You got to take all those things into account as well. If I have a hypokinetic lateral wall and I have ischemic regurg based upon the posterior leaflet not functioning properly because that wall is down, and I go from a hypokinetic to an akinetic wall for transiently after bypass, I'm going to leave it alone because I know that that wall was at least hypokinetic. I have a metastem showing that I had good bypass grafts with good flow and a low pulsatility index. And so I'm comfortable that I didn't cause any damage from that. And so I'm going to think that that transient wall abnormality is related to either subpar myocardial protection. It could be related to air down one of the coronaries, or just maybe some resting or hibernating myocardium.
So you're expecting that later that's going to wake up and this regurgitation that you're seeing is essentially going to go away, or it's going to improve to a tolerable.
Yeah, I mean, generally, I don't ring or address mild to moderate regurgitation anyway in the setting of ischemic cardiac disease, because the literature is always vacillates on that, you know. So you can, so that's just kind of my practice. It's evolved that way. I mean, you can ring everything under the sun, but you introduce a lot of more possible morbidity and mortality by adding those different procedures to a case. And so unless you have solid data to support your decision, then I would tend to err on the side of caution.
Do we have air in the left ventricle or the left atrium? Do you have an image on here, if you know there's one there, of air post mitral valve or post aortic valve? And I really want to talk about air and how that gets addressed and our concerns about it or not. I think only the blue ones are clickable.
I don't know that we have any on this, in this image library.
You want to just go on YouTube?
We can.
Yeah. Hey, Roger, can you go on YouTube and search for left atrial air post mitral valve replacement, TEE, and TEE or whatever. Let's see. You see anything? Scroll down, maybe.
Yeah, you can.
Oh. What about there? Mitral stenosis now. Oh, here, I could type it. I might have to search over again. Let's see. Let's go to, you want to put me back up in the search bar? In the,
I'll let Roger do that.
In that one, yeah.
So what is your question?
TEE. Oh, I want to show you let's look at the image first.
Mm-hmm.
TEE, air in atrium post valve. What do we got? More of the same? You see anything? I don't see anything.
Let's scroll back up.
Scroll back up. Oh, right there.
Removing air status from LV, status post cabbage. Third one down.
Yeah, well, pull that one up. Okay. Yeah. Let's look at this.
So that was, they were transitioning from the short axis view to a long axis view. At the beginning of that clip, you saw the short axis view of the aortic valve, and now they're doing a two chamber long axis view, right? You see the left atrium and the left ventricle primarily. And then the aortic valve is sneaking into the picture there a little bit.
Look at all that air. Look at it.
So that's him sticking his hand in there and shaking the heart, trying to stir up the air.
Yeah.
Mm-hmm. And that little vent that's up in the aorta. Okay. All right. Now you would agree. I mean, that's not a huge amount of air, but that's some air. Significant amount.
Yeah, and also what kind of air is it? Is it room air or is it the carbon dioxide? Because when I do valve procedures, I use CO2 in the field. So some of those air bubbles are CO2, and they're not clinically significant.
Mm-hmm. Mm-hmm. Or at least they're more absorbable.
Yeah.
They're more absorbable. I think if you have a big enough bolus of it, even if it is CO2, but it's still a lot, and it's not all going to be CO2, even if you are flooding your field with CO2.
Mm-hmm.
So why do you get so excitable? Not you, but all of you guys, over that little teeny bubble that's in the connector when you make your connection to go on pump?
I think a lot of what we do is anecdote and historical, and we do it. That's the way we do it because that's the way we do it. But we do know that air is a nidus, or can be a potential pathogen. It can cause an infarct, and so anytime that you can reduce it, I think you should. It's an air bubble in the arterial cannula gets delivered directly to the systemic circulation. So obviously you want to reduce that because you know it could be a problem.
Yes.
So why would you not?
Sure, that's a great answer. No, I'm with you.
I mean, that's a great answer too. And there's a simple answer to that before we take our break. The perfusion mantra, no bubbles, no troubles. That's why you would remove it.
Yes.
Because that's just the perfusion mantra. But then, do you remember Bullwinkle, Rocky and Bullwinkle? And they always had that thing. It would either be, they would have that, what's that thing called where you say something, but you have two things that go with the parables. So no bubbles, no troubles, but what's a little air among friends? Because that's a lot of air. And these patients do, remarkably well, regardless.
They do. But here's the other limitation, is you guys don't follow them long term. Once they get dropped off in the ICU and, the case is over, you guys tend to not be around. No fault of your own, but
that's another good point. When you
extubate the patient, I mean, if we were to do if we do neurocognitive testing, and they've shown this, neurocognitive testing pre-op versus post-op, a lot of these people will have insults. You're able to document an insult. Whether it's clinically significant long-term, that's debatable.
If you did diffusion-weighted MRI on everybody that has heart
everybody
surgery,
has a stroke. Everybody has a stroke. And so that's one of our frustrations when somebody wakes up maybe a little bit goofy or off, or they're just not their self, and then the hospitalist or somebody sends them down for a head CT or an MRI, and now you've got stroke in the chart. Well, technically, yeah, sure. In a purest sense, yeah, maybe they did, but it's not clinically significant.
Is it not clinically significant? That's another question.
Then you have to look at the neurocognitive testing in long term. A lot of those people that have deficits initially will eventually return to their baseline.
Mm-hmm.
And so,
but what is the long-term effect of these insults that occur? And I don't necessarily think we have the full answer on that. Well, actually, I think we do have the answer on that. They're cumulative and they're not good at all. What do we do about that? Because again, you worry about that little teeny bubble that you can barely. You're looking at it through magnification. What do your loops magnify?
Mine are 3.5x.
3.5x. So that itty bitty bubble that I can't see with my glasses probably looks this big to you. But we accept that. Is there anything that can be done about all of that? Do we vent? I don't think our vent captures 10% of it, maybe 20% of it if we're lucky. It's gone. It's going somewhere. Yeah, I know you put them in Trendelenburg, you rotate them, you do all these things to try and minimize the air going up the arch into the head, but it's still going up there. Do we de-air sufficiently after an open cardiac procedure? And is there something else that should be being done?
Open cardiac, I mean mitral.
Valve,
okay.
Anything where we're opening the heart, the chambers themselves, where we're getting air inside the heart.
Yeah, I mean, when you have a perioperative stroke rate of less than 1%, yeah, I think you're doing a sufficient job of de-airing. I don't think that we need to change the algorithms. Now, whether we're doing too much or is the air that we see as significant as we think it is? Probably not. I mean, that's probably true with a lot of stuff that we do. But who's going to study that? You know, would you sign up for that study?
Patrick.
We're going to either de-air you or not de-air you. Are you willing to sign up and be in our study?
So let's go back to this other question of we drop them off in the ICU and we're gone. I mean, that is just the way it is. It's been that way for a very long time. Should that change? Should we, since we've been talking today about learning more about imaging, understanding more what's going on with the patient from that perspective, do you think perfusionists should have more awareness, not involvement in the care of the patient, awareness of the outcome of the patient beyond just dropping them off in the ICU, at least out of the ICU and to the floor? I'll get both of your opinions about this.
I do not think that we should have more. We can look at, since somebody is following that patient, we could probably do just as well having the data and the information than actually making a visit or a round to that patient, in my opinion.
What's your opinion?
Well, I think it's great. I think it'd be great to be involved. I don't necessarily mean you make rounds on the patient, document in the chart and things along those lines, but be aware, absolutely. Yeah. And to a certain extent, you're already aware because you guys are on all of our quality committees. You know, when we present our STS data and go over our results, perfusion is there. And so you are part of that process. It may not be a bedside process, but it's a quality process. And I think that anytime you can incorporate everybody that touches that patient into the heart team, it fosters ownership in that program, and I think that drives quality because you're personally vested.
Yeah, I would agree with that. I have to disagree with you on this, though. I understand the reasons. I understand your reasoning. I don't agree with it, but I understand that is the way it is. If you don't mind, the way it is a phrase that it was designed to explain all that is unexplainable in the universe. It's just the way it is. So, but I don't think it's right. And I think it's uncomfortable because we don't do it. But if we were just walk through the ICU every, day, of course, it's tough to do when you go to 5 or 6 different hospitals. I grant you that. You might have done a case at this hospital and you're not going to go back there for a period of time, which means you would have to make that special trip. But to walk through the ICU and say, hey, how's so-and-so? You don't have to see the patient or talk to the patient, just see the nurse or walk by. You could even walk by and look, they're sitting in a chair and they're eating. That's a pretty good, I think, indicator that patient's doing pretty well. If they're still intubated and they're tied to the bed, that's an indication that maybe things aren't going so well. They might have some psychosis or some kind of neurologic problem or just whatever it may be. Or they're not there at all. That's a real clear indication that something might not have gone very well. And I think that we don't do it. But I think it's uncomfortable for us, and I think it's uncomfortable to even talk about it. But I really question whether or not that isn't something that we should do. Again, it goes right back into this whole concept that I have that are we a part of the team or not? And I'll tell you something. And I'll tell this to all of my colleagues as well out here in Webland. There is not a whole lot more you can do to the patient other than what he does, which is cutting them and sewing them and doing all these things. But there's not a lot more you can do that can be as intimate as what we do to them. I mean, we basically are their lifeline for whatever period of time we're on bypass. I mean, we're pretty intimate with these people, but yet we treat it kind of like an assembly line. They come in, we get the chart, we figure out our stuff, we do the case, go on pump, come off pump, clean up, take them to the ICU, drop them off. Some places don't even do that. And we're on to the next one, or we're on our way to the links. It's one or the other. I'm not so sure that's the best way to do it.
Yeah, I don't know that it's, certainly you're kind of touching on kind of an emotional attachment to what you're doing and to the patient and that sort of stuff. And
I'm an emotional guy.
Yeah, I know, but not everybody is, and so, and I can understand Patrick's perspective is like, look, I did my job, I did it to the best of my ability, it's time to move on, I don't want to go, wave people across the room and see how they're doing. That doesn't mean a lot to me, and that's fine as well. But I think that, maybe, checking on these people periodically post-operatively certainly gains you perspective as to the whole process. You can understand why I'm on edge during XYZ portion of the procedure when I may or may not be that type of person in general and things along those lines. I think that it just kind of gives you a better understanding of the entire process and the disease process rather than just the snapshot of that 2 hours, 3 hours, 4 hours that you're in the operating room with them.
If there is anybody who's watching and can maybe call in and say, tell us if you do visit patients, that'd be kind of helpful to hear why they do and if that,
anecdotally, I think a lot of perfusionists do that. If we have a tough case or, things get sideways and we end up on an Impella or a balloon pump, it's almost uniform that the next day, when I see that perfusionist or the next time I see them, they're like, well, how did that patient do? It's not that there's a complete disconnect there.
Right.
But I think that, specifically going by on your own time to kind of see how things are and see what that process is immediately after gives you a lot of insight and perspective.
And I think that's easier to do when you are a single site.
Oh yeah, absolutely.
Clinician. When you're going to 4 or 5, 6 different hospitals, I think that 8 different hospitals, I think that makes it much more difficult to do that. And, of course, it makes me wonder if that's the right way to do things. Should that really, this discussion could really go down a rabbit hole. Should programs that do 50 or 60 cases a year and that's all exist? But, we can maybe have these discussions for another day. Jennifer asked a really good question. What kind of normal changes would you expect in a TEE before and after the chest is opened and then after it is again closed? Are there any just changes that occur due to
simply closing the chest? Yeah, I think that once you open the mediastinum, you think of the mediastinum, it's a confined space, right? It's got anteriorly you got the sternum, posteriorly you got the spine, and then laterally you have the pleura. And the pericardium more specifically is, it's a closed space. And anytime you open that space, you provide an outlet for any kind of pressure gradient that's across that space. And so if you open the sternum and then open the pericardium, I would expect the CVP to drop a little bit. You may see a decrease in the pulmonary indices.
But what about your TEE images? Will there be any changes, I guess, in terms of, I'm assuming her question has to do with, would you see anything change in terms of your valves? Anything different in terms of, with the heart now sort of free to move around? Yeah. Will there be differences?
No, I think that if you have your echo probe in a specific location, of the heart, and then you open the sternum, the heart can shift a little bit, so you may have to adjust the orientation of your transesophageal echo. But I never expect a change in the wall motion, the characteristics or the quality of the wall motion,
or create a valvular problem.
or the valve function to change in any way measurable by simply opening the chest.
And then closing it.
So yeah, so you know, to extrapolate that into the closing of the chest, sometimes, you know, you close the chest and their pressure may dip or something along those lines. I don't expect the function and all that to really be changed that much. You should not. If it does, then there's something wrong. But I don't expect
There's a lap in there, you're pushing down.
Right, I don't expect
something
a normal physiologic change to take place.
Okay, well, hopefully we answered your question. Okay, how about if we take another short break?